Good afternoon. This is the YouTube recording for chest trauma and thoracic injuries. Traumatic injuries to the chest occur in about 20% of trauma incidents and account for about 9% of trauma deaths. There are two mechanisms and categories or injuries to the chest: blunt trauma and penetrating trauma. Blunt trauma occurs when the chest strikes or is struck by an object. Deceleration, acceleration, shearing, and compression. Penetrating trauma occurs when there is an open injury to which a foreign body impales or passes through the body tissues. Examples of these include knife wounds and gunshots. A pneumothorax is air in the pleural space. As a result of this air in the pleural space, there is partial or complete collapse of the lung. A closed pneumothorax has no associated external wound. The most common is a spontaneous pneumothorax. This can be caused by rupture of small blebs on the visceral pleura. These are caused by airway inflammation, most commonly due to smoking. Injury from broken ribs can also cause pneumothorax, as well as placement of a subclavian catheter. Excessive pressure during manual or mechanical ventilation can also cause a closed pneumothorax as well. An open pneumothorax occurs when air actually enters the pleural space through an opening in the chest wall. A stab wound, a gunshot, with surgical thoracotomy. Penetrating chest wounds are often referred to as a sucking chest wound, as air can be heard during inspiration. The wound needs to be covered with an occlusive dressing and secured on 3 sides. We should not ever secure all of the sides, as this can cause a tension pneumothorax. If the object that caused the open chest wound is still in place, do not remove until the physician is present. Stabilize the object with a bulky dressing. A tension pneumothorax is when air accumulates rapidly in the pleural space. This can cause high intrapleural pressures. This results in compression of the lung on the affected side and pressure on the heart and great vessels, pushing them away from the affected side. This can result from open or closed pneumothorax. The mediastinum actually shifts toward the unaffected side, which compresses the other lung. As pressure increases, venous return is decreased and the cardiac output falls. This can occur with mechanical ventilation and resuscitative efforts. This can also occur if the chest tube is clamped or becomes blocked in patients who have a pneumothorax. Symptoms include dyspnea, chest pain that radiates to the shoulder, tracheal deviation, decreased or absent breath sounds on the affected side, neck vein distension, and cyanosis. Hemothorax is an accumulation of blood in the pleural space. This changes the pressure and will cause a collapse of one or partial of the lungs. A chylothorax is actual presence of lymphatic fluid in the pleural space. Patient may require pleurodesis if it is from possible malignancy. In this picture, you can see where the lung has collapsed and you see the air around it in the pleural space. This also demonstrates a pneumothorax, but also shows you a tension pneumothorax because you see the mediastinal shift that has occurred, causing compression on the heart and the lung on the other side. If a pneumothorax is small, the patient may experience some mild tachycardia and may complain of some dyspnea as the only manifestations. If it is a larger area, they may actually have respiratory distress, including shallow rapid respirations, dyspnea, air hunger, and oxygen desaturation. On the chest X-ray, the presence of air or fluid in the pleural space and a reduction in lung volume will be seen, as demonstrated in a previous slide. Attention pneumothorax is a medical emergency, and the treatment will depend on the severity and the nature of the underlying disease. On auscultation, you will not hear any breath sounds over the collapsed lung area. With tension pneumothorax, respiratory and cardiovascular status are compromised, and if not treated promptly, the patient can die. Emergency management that is done initially would be to insert a large bore needle into the anterior chest wall at the 4th or 5th intercostal space. This will release the trapped air. Then a chest tube can be inserted and connected to water seal. With fractured ribs, this is the most common type of chest injury that results from any type of blunt trauma. Ribs 5 through 10 are most commonly fractured because they are the least protected by chest muscle. Patients complain of pain at the site, especially during inspiration and when they cough. Our main goal of treatment is to decrease the pain so our patients can breathe adequately. We do non-steroidal anti-inflammatory drugs. We can do opiates. They can do nerve blocks at the specific area. They also utilize lidocaine patches to help. The patient needs to continue to cough and deep breathe and use an incentive spirometer, as failure to take deep breaths can cause atelectasis and pneumonia. If the fractured rib is splintered or displaced, it can actually damage the pleura and the lungs and cause a pneumothorax. These patients will splint the area and take shallow breaths, as discussed earlier, to try and decrease the pain. This is why it is so important that they are keep their pain under control and continue to cough and deep breathe and use an incentive spirometer to prevent atelectasis and pneumonia from the decreased ventilation and the retained secretions. In the event of a flail chest, this is when fractures of 2 or more ribs in 2 or more separate locations have occurred. These areas are unstable. It can cause a paradoxical movement with respect to the intact portion of the chest during respiration. And what we see with the paradoxical movement is that during inspiration, the affected portion is sucked in, and during expiration, it bulges out. These patients will be tachycardic. They will have rapid, shallow respirations as well. Initial therapy, we need to manage their airway. Some of these patients may require intubation until they can heal and get their pain under control. Hydration, and again, pain control with these folks. Unfortunately, with flail chest, it prevents adequate ventilation of the lung in the injured area and increases the work of breathing, which is a lot of the reason why these patients may require a short period of intubation and ventilation. Chest tubes are utilized. They can be done in the emergency room, they can be done at the patient's bedside, or they can be done in the operating room in situations where there's been some kind of surgical procedure that may cause partial collapse of the lung. The patient may be seated on the edge of the bed or lying supine. I've not assisted with a chest tube insertion on any patients that have been actually seated. Normally they're lying supine with the mid-axillary area of the affected side exposed. That area is up so that the procedure can be done. The area is cleansed with a ChloraPrep. The chest wall is prepared with an anesthetic, and the surgeon makes a small incision over the rib to help with placement of the chest tube. The chest tube is then advanced up and over the rib to avoid the intercostal nerves and the blood vessels. If the purpose is to remove air, the tube is actually directed anteriorly and superiorly. If the purpose is to remove fluid, it is directed posteriorly and inferiorly when it is inserted. The insertion of the tube allows the removal of the air and also removal of any fluid, which allows the lung to expand. After thoracotomy, a chest tube can also be placed through a stab wound that's adjacent to the surgical incision. The chest tube is then connected to a pleural drainage system. Two tubes can be connected to the same drainage unit with a Y connector. The incision is closed with sutures and the chest tube is secured. And then an occlusive dressing is applied after that. This is an example. In here in the illustrations you can see the chest tubes. You have one that is placed anteriorly and you have one that's placed posteriorly. The second intercostal space, it goes up towards that area, that is to remove air, and when it is going posteriorly, that is to remove fluid when it's in a lower area on the chest. You have two types of systems that are utilized for a chest tube or pleural drainage. You have either a closed or water seal, or dry seal that can be done. We also have what's called a Heimlich valve. It actually has a flutter valve connected to a drainage bag. It's a very simple apparatus that consists of a one-way valve within a rigid plastic tube. It is attached to the external end of the chest tube. This can be used for patients with chronic pleural effusions so that they can go home with these to continue to drain those chronic effusions for that patient. This is an example of what the flutter valve looks like, and that can be used for patients to go home with. The second, which includes two different types, the water seal and the dry suction, it's much longer and it actually contains three basic compartments, each that have a separate function. The collection chamber is the one in which receives fluid and air from the pleural or mediastinal space. The fluid stays in this chamber while the air vents to the second compartment. The water seal chamber, this actually contains 2 centimeters of water, which acts as the one-way valve. The incoming air enters from the collection chamber and bubbles up through the water. Your suction control is where you actually apply the suction to the chest drainage system. Again, there are two types. There's a water and a dry. The water suction uses a column of water with the top end vented to the atmosphere to control the amount from the wall regulator. The chamber is typically filled with 20 centimeters of water. This is all included in the Pleurovac set that the nurse is responsible for setting up for the physician. In a dry suction, it contains no water. It actually has a visual alert that indicates if suction is working, and you actually do kind of a dial-up on it to the amount of suction that you want. It's used to 20 centimeters of suction. If you need to increase the suction pressure, you turn the dial on the drainage system. But the maximum usually is 20 centimeters of suction that your physician is going to want for your patient to have. This is an example of the water seal drainage system. You see where it is the water seal chamber where you have the 2 centimeters of water. It should not be bubbling. It should rise and fall with inspiration and expiration. You have your collection chamber, and you see you have the markings where you can actually measure the amount of any fluid that comes out of the lungs. You have your pressure level. Again, you have your water-filled suction chamber. It should be at 20 centimeters, as you see there. The water is actually put in through the vented area into that chamber, and you want to monitor, make sure that your suction is not too high because it will evaporate the water as it bubbles. So you want to make sure that it is just enough to keep it at the 20 centimeters, but not so much that it has excessive bubbling. The dry suction, again, there is no real water seal chamber. You have an indicator, you do the dial. Some of these are different. The dial on some of them, when you look at the Pleurovac system, it's orange, and you actually dial it up on the front of the container. Still, the other chambers are the same, your collection chamber for you to be looking at with the patient. Please review your nursing care guidelines that are in Table 2823. It's very important to remember that you do not clamp any chest tubes during transport or when the tube is accidentally disconnected, as this can lead to a tension pneumothorax. Should your chest tube become disconnected, you can place the chest tube in some sterile water, the end of it, until you can get a new system set up. This keeps the lung from collapsing. The chest tube will be removed once the lung has re-expanded and the fluid drainage has ceased. The chest tubes are removed. Normally, if you have someone who is on water sealed or is on suction, they will do a water seal initially, where they take them off the suction and continue to monitor to make sure that the lung stays re-expanded. Once this is assured, then they will plan on removing the chest tube. Again, generally the suction is disconnected and the chest drain is on gravity or water seal for the 24 hours prior. You will need to explain the procedure to the patient and what's going to happen. The physician will ask the patient to hold their breath, and or they will bear down as the tube is removed. This helps with the intrathoracic pressure to maintain expansion of the lung. Once it is removed, they will cover the site with an airtight dressing. It's usually with a petroleum dressing. The pleura will seal off and the wound will heal in several days. A chest x-ray is going to be ordered, and it will be done to evaluate to make sure that the pneumothorax has not reoccurred, and or to make sure there's not a reaccumulation of fluid. You need to monitor your patient for any signs and symptoms of respiratory distress after the chest tube is removed. This could signal recurrence of a pneumothorax, and you need to monitor the wound site for any drainage that may occur. Chest surgery is performed for a variety of reasons, some which may not be related to primary lung problems. Please review Table 2824. Preoperatively, your patient's going to have a baseline data on their respiratory and their cardiovascular systems. They will have gotten diagnostics that include pulmonary function tests, some chest x-rays. They will have an ECG. They will have ABGs. They will have electrolytes and CBC done. Anesthesia will be consulted. Their pre-op teaching, of course, they will need to know about use of incentive spirometer, to expect that they may come back with chest tubes, and that they could possibly be on a ventilator short term after surgery. Chest tubes are placed sometimes after chest surgery or surgical therapy. Your patient could have a thoracotomy, which is a surgical opening into the thoracic cavity. This is a major surgery. It's a large incision. It cuts into bone, muscle, and cartilage. It can be either done as a median sternotomy or lateral thoracotomy. The VATS that we talked about earlier, it's through these areas that they can inspect the chest cavity, they can biopsy, and they can actually do removal of tissue or lung. Again, postoperative care, refer back to 28.2, and follow-up will depend on the type of surgical procedure that the patient has. Their chest tubes are placed in order to re-expand the lung because they have opened up the thoracic cavity, which can cause collapse of the lung. Pain is controlled either with use of a PCA and a lot of times with intercostal nerve blocks that are done at that time. So we're now going to move on to restrictive respiratory disorders. These are disorders that actually alter the ability of the chest wall and the diaphragm to move with respiration, and these are known as the restrictive respiratory disorders. Pleural effusion, this is an abnormal collection of fluid in the pleural space. It's not a disease, but it is an indication of a disease. There are 5 processes that can actually lead to pleural effusion. There can be an increased production of fluid due to increased oncotic pressure. It could be increased production of fluid due to increased capillary permeability, such as we have with infections and sepsis. The patient could actually have bleeding into the space. They could have decreased lymphatic clearance of pleuritic fluid, such as when we have metastasis from the lungs with a cancer. And it can also be due to infection. You also have different looks of the fluid when we go to remove it. You have a transudate. This is what you see in non-inflammatory conditions. It will be clear, pale yellow in color. And this is usually because you have an increased hydrostatic pressure when you see in heart failure or in hypoalbuminemia, which is found in your chronic liver or renal diseases. Exudative is when you have capillary permeability, and this is a result of inflammatory response or reaction. It could be secondary to malignancies. The patient can have an infection. There could be some necrosis. They can also develop pleural effusions with pancreatitis, or if there's an esophageal perforation that has occurred for some reason, such as when people have fish bones, or we had a patient that had swallowed a chicken bone and actually perforated the esophagus. So with that, led to some serious problems with the trachea and with the lungs in trying to get that repaired. On this as well, with pleural effusions, you can have an empyema, which is actually a collection of purulent fluid in the pleural space. We see this sometimes with pneumonia. You can see it with tuberculosis, when the patient has a lung abscess from an infection. A complication of this, of course, is fibrothorax, in which there's fibrous fusion of the viscera and parietal pleura. So it actually adheres to the pleural area, which decreases movement of the lung for the patient. So with pleural effusions, the patient can complain of some dyspnea that progresses. They have decreased movement of the chest wall on the affected side, and they'll complain of pleuritic pain. If you were to percuss the area, it is dull to percussion, and you can have absent or distant breath sounds that are noted. Chest X-ray will reveal the volume and location of fluid. And again, manifestations of empyema include all of the above, as well as the patient can complain of fever, night sweats, cough, and weight loss. The patient may require to have a thoracentesis done, which is actual aspiration of the intrapleural fluid. It can be done for diagnostic, and it can be done for therapeutic purposes. Usually only about 1,000 to 1,200 mL is removed at any one time from the patient. Rapid removal of a large volume can actually result in some complications. The patient can become hypotensive. They can develop hypoxemia, or they can have a rebound and develop pulmonary edema. During and after the procedure, it's important that you monitor vital signs and pulse oximetry on your patient. These patients, when they have a thoracentesis, they can be sitting up. Normally they're up over a bedside table, and or they can be lying down. A lot of times, sometimes large volume is done downstairs, but they really try to avoid that because you do not want the rebound effects and the complications that can occur. We always want to treat the underlying cause if the pleural effusions are due to some type of malignancy. These patients, again, may have to have a pleurodesis to try and where they actually have a chest tube in, and they actually insert medications in through the chest tube to sclerose the area around the lungs so that the pleural effusions will not occur anymore. So when we talk about pleurisy, this is an actual inflammation of the pleura. Most commonly is caused by pneumonia. You can have some chest trauma, pulmonary infarctions, can be because of neoplasms as well. They complain of an abrupt and sharp pain which is aggravated by inspiration, and when someone has pleurisy, you're going to possibly hear a pleural friction rub. Our treatment is aimed at the underlying cause and providing pain relief for the patient. So now we're going to talk about pulmonary hypertension. This is elevated pulmonary pressures that result from an increase in pulmonary vascular resistance to blood flow. It's a disease commonly manifest with shortness of breath and fatigue. It can occur as a primary disease or as a secondary complication of a respiratory, cardiac, or autoimmune illness, or hepatic illness as well, or connective tissue disorder that the patient has. We're mainly going to talk about primary pulmonary hypertension. It's a severe and progressive disease. It's characterized by the mean arterial pressure or pulmonary arterial pressure is greater than 25 millimeters of mercury at rest. The normal pressures for the pulmonary artery are 12 to 16. If with exercise, if it's greater than 30, then it's considered they have primary pulmonary hypertension. Their clinical manifestations, again, they have dyspnea on exertion. This has gotten progressively worse. They have exertional chest pain, some dizziness, some exertional syncope as well. And these symptoms are related to the inability of cardiac output to increase in response to their increased oxygen demands. Eventually, dyspnea will also occur at rest as this disease progresses. When we look at diagnostics, it's really a condition that must be ruled out. It's a diagnosis of exclusion of all these other conditions. We evaluate an ECG, we look at chest x-rays, we look at their pulmonary function test, an echo, spiral CT, but definitely a cardiac catheterization can give a definitive diagnosis for the patient. The chest x-ray is going to show enlarged central pulmonary arteries while the lungs fields are clear. And it's not unusual for the heart to be enlarged as well. Echo reveals right ventricular hypertrophy to be present. And again, the cardiac cath is utilized to measure the pulmonary artery pressures, the cardiac output, and the left ventricular filling pressure. And again, the cardiac cath is the most definitive of all those diagnostics that are used. This is just a visual map of the pathophysiology of primary pulmonary hypertension. As we stated earlier, there can be genetic causes. There can also be some unknown causes. You have pulmonary endothelial injury, which increases the vasoactive mediators, which causes vasoconstriction. Think about your patients that have COPD. They have a lot of vasoconstriction, so which leads to remodeling. The walls are thicker on the vessels. They can have some coagulation and fibrinolytic defects that can precipitate thrombosis to occur. So then they start having the sustained pulmonary hypertension because of all the vasoconstriction, and now you have the thickened walls of the vessels. Patients develop right ventricular hypertrophy, and they can develop cor pulmonale, which leads on to right-sided heart failure. It's not unusual for this to occur. A lot of your COPDers can end up with cor pulmonale, again because they have all the vasoconstriction that occurs because of the high CO2 levels that they maintain, and can end up with right-sided heart failure. It is a collaborative care. Early recognition is key to help interrupt the cycle of progression for these folks. Treatment can relieve symptoms and increase the quality of life and actually prolong life. We utilize diuretics to help relieve dyspnea and the peripheral edema. Anticoagulants can be necessary because this helps to prevent thrombus. Hypoxia is a potent pulmonary vasoconstrictor, so our goal is to utilize oxygen and to maintain their O2 sats greater than 90%. Calcium channel blockers such as Procardia, Cardizem actually dilate constricted pulmonary arteries and thus reduce pulmonary hypertension. When we assess a patient to see if our medications are working, it's not about blood pressure for them. It is a relief of their symptoms. If they state that their dyspnea is better, then that is where we're looking at that our medications have been effective. There is a class of drugs that you're likely to see. Sildenafil or Revatio. This is like the Viagra. It prolongs the vasodilatory effects of nitric oxide and is effective in decreasing pulmonary vascular resistance. If a patient is placed on this medication, again, just like with Viagra, they should not be on nitrates, and they should not take any nitrates, as this can cause severe hypotension, and with some patients it can lead to death. Secondary pulmonary hypertension, again, as I talked about earlier, this can occur with your patients who have a chronic increase in pulmonary artery pressures. It can develop with parenchymal lung disease, left ventricular dysfunction, chronic pulmonary thromboembolism. You have an anatomic change that occurs, loss of capillaries because of alveolar wall damage, as what we see in COPD. You have stiffening of the pulmonary vasculature that occurs, pulmonary fibrosis, and you have obstruction of blood flow like you see with chronic emboli. The symptoms reflect the underlying disease process. Again, complaining of, just like with systemic pulmonary hypertension, or excuse me, secondary pulmonary hypertension, they have dyspnea, they have fatigue, they have lethargy, and they may complain of chest pain. Physically, there's going to be some right ventricular hypertrophy, and they're going to have signs of right ventricular failure. Again, treatment all is about the underlying cause of what's occurring. With cor pulmonale, initially it can be subtle, and sometimes it's masked by the pulmonary condition. They can have dyspnea on exertion, they can have lethargy, they can have fatigue. Physical signs actually include right ventricular hypertrophy on an ECG, and you have an increase in the intensity of the second heart sound when you're auscultating heart sounds. The chronic hypoxemia leads to polycythemia, an increased total blood volume, and a viscosity of the blood. These patients with cor pulmonale a lot of times will have to have plasmapheresis, or have, excuse me, not plasmapheresis, they will actually have to have blood draws to remove blood to assist with the viscosity and the total volume. Collaborative care, of course, is management at the underlying cause. They will need long-term low-flow O2 therapy to correct their hypoxemia, which helps to reduce the vasoconstriction. Diuretics and low sodium diet to decrease plasma volume and reduce the workload of the heart. And again, phlebotomy is indicated in those patients with a chronic cor pulmonale and chronic hypoxemia, especially if the hematocrit is greater than 65%. If the enlargement of the right ventricle is secondary to diseases of the lung, thorax, or pulmonary circulation, pulmonary hypertension is usually a pre-existing condition in the individual with this. Again, the most common cause is COPD. If heart failure is present, there will be peripheral edema. There's going to be weight gain, distended neck veins. They're going to have a full bounding pulse, and the liver will also be enlarged. Again, these are just examples of some diagnostic. You need your history and physical exam. We're going to look at their ABGs. We're going to look at their serum and urine electrolytes as well. The patient's going to need an ECG, and as I stated, it will show right ventricular hypertrophy. We're going to look at their O2 sats and see if they have a chronic hypoxemia. And we're going to look at the chest x-ray. Likely you're going to have an enlarged heart, as well as you're going to have some enlarged pulmonary arteries. They're going to need to be on their low flow O2. We're going to need bronchodilators, diuretics. Also, they are possibly need some calcium channel blockers for treatment. In regards to lung transplantation, this is a common indications for lung transplant include COPD, idiopathic pulmonary fibrosis, cystic fibrosis, the alpha-1 antitrypsin deficiency, and pulmonary hypertension. With lung transplant, it's utilized for a variety of these patients with end-stage lung diseases. Usually, a lot of times when they do lung transplant, patients are evaluated for transplant, and if they meet the criteria, then they are put on the waiting list. Very important, the biggest thing when someone has a lung transplant, the care. They are going to be on a ventilator for a while. They are going to have chest tubes because of the surgical incision. Routine post-op care in staging them and getting them off the ventilator. And the biggest thing is they're going to be on immunosuppressive drugs. So they are at high risk for infections. And also you have to monitor them for potential for rejecting of the organ. The number one reason for mortality after a lung transplant is due to infection post-op or post-transplantation.